Welcome to the Catholic Ethics and Challenge of COVID-19, a live webcast series presented by the Catholic Health Association and Georgetown University in cooperation with the Pellegrino Center for Clinical Bioethics. Thank you for joining us. My name is Ronnie and I'll be the operator for today's presentation. Before we get started, I'd like to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any of your computer volume settings. There will be a question and answer portion of the webinar. To submit a question, please locate the Q&A chat bubble at the bottom toolbar of the Zoom platform. Please note that today's presentation is being recorded and you'll be emailed the recording. We are joined today by Nate Hibner, Director of Ethics for the Catholic Health Association. At this time, I'd like to turn the presentation over to Nate for opening remarks. Nate, the floor is yours.
Thank you, Ronnie, and good day, and thank you all for joining us for the second part of our special series presented by the Catholic Health Association and Georgetown University, entitled Catholic Ethics and the Challenge of COVID-19. Before I introduce today's presenters, let us take a moment and reflect and say a prayer together for all those who are in need. May we who are merely inconvenienced remember those whose lives are at stake. May we who have no risk factors remember those most vulnerable. May we who have the luxury of working from home remember those who must choose between preserving their health or making their rent. May we who have the flexibility to care for our children when their schools close remember those who have no options. May we who have to cancel our trips remember those that have no safe place to go. May we who are losing our margins in the tumult of the economic market remember those who have no margin at all. As fear grips our country, let us choose love. During this time when we cannot physically wrap our arms around each other, let us yet find ways to be the loving embrace of God to our neighbors. Amen. We are pleased to be joined today by three distinguished presenters from Georgetown University who will focus on the topics of rationing care and preferential treatments. For the first half hour, we'll be joined by Dr. Daniel Solmese, who is professor of biomedical ethics in the departments of medicine and philosophy at Georgetown University, where he's the acting director of the Kennedy Institute of Ethics and a member of the Pellegrino Center for Clinical Bioethics. For the second half hour, we'll be joined by Dr. Claudia Sotomayor, who is a clinical ethicist at the Pellegrino Center for Clinical Bioethics, as well as an adjunct assistant professor of internal medicine of Georgetown University Medical Center. She will be in conversation with Dr. David Miller, who is the associate director for academic programs and administrator for the Center for Clinical Bioethics at the Georgetown University Medical Center. Welcome to them all. Today's event, as last week, is divided into two 30-minute sessions in which you can submit questions for the presenters, as Ronnie explained, through the Q&A box. In the first session, Dr. Solmese will discuss rationing criteria for ventilator eligibility, and in the last half, Dr. Sotomayor and Miller will focus on the topics of preferential treatment for medical personnel and first responders. So with that, I'm going to turn over to Dr. Solmese to begin his discussion.
Well, thank you, Nate, for that very gracious introduction. Thanks for everyone who's listening in and watching. I'm going to talk for, I hope, just about 10 minutes on the ethics of rationing ventilators in the face of an overwhelming surge of patients with COVID-19. And then following that, there'll be some Q&A for the rest of the session. But I'd like to begin by starting with one very fundamental premise. This is a message I've been trying to give to anybody I can talk to about ethics in the setting of the COVID pandemic, which is this, that the circumstances don't dictate our ethical principles. In fact, what we always do is apply our ethical principles to whatever the circumstances are that we encounter. And when the circumstances are extraordinary, The message is that we need our ethical principles even more than we did before. I'm sort of getting very disturbed by all that I hear about this pandemic is changing everything, as if we have to throw our ethics out and start all over again. That's not the message. We need our ethics and our principles now more than ever. In ordinary circumstances, the most salient principles that we typically rely on in patient care are these two. The first is our duty to benefit patients. One of the corollaries of this is that we don't harm them. But another corollary is that we do not do what does not benefit them. That's a corollary that is often ignored in practice, but is very significant, particularly in acute shortages. But it's present in all of care. The second ordinary duty is to show respect for patients as persons. And the way we typically do that is to show appropriate respect for them as moral agents, what we sometimes call respecting their autonomy. But the fundamental is we're respecting each individual as a unique person with dignity, and the way we typically demonstrate that for them is to show respect for them as moral agents. That's ethics as normal, the way we usually practice. There are two other ethical principles that are always present, actually, even in ordinary circumstances, but they come to the foreground if there's an acute shortage. One of those is solidarity, our commitment to being respectful of the common good. And the way that I would suggest that we think about the common good is not just the way a utilitarian would, it's merely arithmetic, summing up the individual good of each person, but an integral sense of the common good, in which the good of each of us is partly determined by the good of the whole. That my good is partly determined by what happens to the whole. The second principle is that of justice. Again, always present, but foregrounds in the setting of acute shortage. Two aspects to that are critical. One is equity, that we treat all persons as equal on the basis of nothing but their humanity alone. And the second is fairness, that if we are in a situation in which we need to distribute burdens and benefits, we do so in a way that is reasonable, as objective as we can make it, transparent, shared by everyone, and applicable to everyone. Those are important principles, and they are all at play, including the first two in our response to the COVID-19 pandemic. Again, ethics as usual, but in this intense set of circumstances. Virtues always also have a part in medical ethics, but in particular in the setting of a pandemic and the stress that that brings upon the system, very, very, very important. We become professionals, of course, by having professed to care for our patients, by swearing our oaths. And the situation of illness gives our patients no recourse but to trust us, to trust that we can be called upon as persons of virtue who have professed to care for them. Some of those virtues are practical wisdom or phronesis, fortitude, temperance, and justice, all of which are really critical if you think about it in our response to a pandemic. Professional virtues are also important. Competence, altruism, putting the needs of patients, at least to some degree, above our own, being faithful to the trust they put in us, being compassionate, being humble, and being honest. These are all virtues that the fight against COVID-19 is going to demand of us. That said, the first way to think about this is that there's an ethical mandate to avoid rationing, to do everything we possibly can to avoid having to deny potentially beneficial care to patients. This is partly because of our respect for them as persons, which includes then beginning to talk to people as we would under normal circumstances when they come into the hospital and asking about whether they wish to forego life-sustaining treatments in a general way, not just in a pandemic. And secondly, in terms of beneficence, for those who do want us to do everything that we reasonably can for them, We need to try to do things to increase supply of materials, to use alternatives that are almost as good. For instance, if CPAP works as well, or perhaps some data are emerging better than a ventilator, we use that. We transfer the patients if necessary. Perhaps we can act as a health system. Many people, I'm sure, are on this webinar are part of healthcare systems. Maybe it's a chance to be creative. You can find ways that people have figured out, if it's really pressed against the wall, to share ventilators, at least temporarily. Or there were even people who used a combination of scuba masks and 3D printing in Italy to make makeshift ventilating devices for patients. Everything we can to make sure that we're doing what we can to the best of our ability for our patients, short of rationing. But if it comes to rationing, it should be based, I think, on these three fundamental criteria: whether the patient needs it, what the patient's prognosis is, and whether it will be effective. Ethical rationing is not based upon individual characteristics that are not related to need, prognosis, and effectiveness. To do otherwise would be to say that we are not respecting the equal individual dignity of every single one of the patients. What we should be deciding if we need to ration is whether the treatment is worthwhile, not whether the person is worthy of treatment. So on that basis, I would argue that age alone should not be a criterion. We shouldn't use absolute age cutoffs. We shouldn't aim to maximize total life years or quality adjusted life years, because these automatically introduce a bias against the elderly and the disabled. Age will, of course, figure into our estimate of effectiveness, but again, it's a judgment about whether the treatment is worthwhile, not whether it's worthwhile treating this older person. Disability alone should not be a criterion. There were, at least initially in Alabama, protocols being circulated that would just eliminate ventilators for people who are demented or retarded. We can't be true to the principle that we're judging whether the treatment is worthwhile, not whether the person is worthy of treatment, if that's our criterion. Nor should social worth be a criterion. This was actually boldly used by the Spanish intensivists, and we shouldn't be trying to pit the rich against the poor or the educated against the less educated. We should be basing our rationing decisions on concern for the common good, not trying to create a war between different classes of persons, by equitably applying the rules so that they apply equally to all persons. How do you effectively do this? Well, again, as I said before, do everything you can to avoid triage. But then there should be some sort of a trigger mechanism, either that's from the government or your health system, or maybe it's locally just your chief of intensive care. We've run out of ventilators. We need to ration now, and that starts the protocol. And how do we actualize these need, prognosis, and benefit criteria? Need is a basic medical decision, whether the patient needs a ventilator or not. It's the standard kind of decision people will make about whether to ask for a medical intensive care unit consult. Does the patient need a ventilator? Do they actually need a ventilator? But instead of consulting the MICU, it may be that what you're best doing is now consulting a triage team, which might consist of several people. I would suggest at least one clinical ethicist and at least one critical care physician who's not on service, who can help to try to make the judgment or actualize it. The triage team would have more than one person, so to keep everybody honest. But one of the things that that does is separate the team that's treating the patients from those who are excluding the patients, and I hope would reduce moral distress, as well as introduce some objectivity into the decision. Prognosis. I think if we're in a triage situation, patients who, to a reasonable degree of medical certainty, have a less than 6-month life expectancy could be excluded. And the justification for that would be that they are unlikely to survive to hospital discharge. These would all be people who are very, very sick. So it would be ineffective in that sense. And even if they were to get out of the hospital, it would be for a very short period of time. And it would seem that if we were in this sort of situation, it would be reasonable to exclude those persons for the sake of the common good. But I'm talking about really people who are dying, people with metastatic cancer refractory to treatment, really end stage heart failure with reduced ejection fraction, class 4 symptoms, hyponatremia, very low ejection fraction, etc. But if the patient needs it and they're not terminally ill, then you have to have the triage team doing some kind of rationing. I would suggest that could be done with the aid of a scoring system. I would suggest for technical reasons Apache 2 over SOFA, but something like that. So you say over a score of 35, where there's a mortality of over 85% even outside of COVID-19, that person could be excluded, and then patients would be ranked according to their score. People have talked in many protocols about tiebreakers. I would not, even at the tiebreaker stage, introduce patient characteristics that are unrelated to need, prognosis, and effectiveness, such as age, disability, or social worth. I would say then if people, for some reason, which would be bizarre, come at the same time, have the same exact SOFA score or Apache score, that it just be the first one there gets the treatment and the second one is put on the waiting list. Again, if that were to even be a tie, but they come at the exact same time, then I would just say that there should be clinical judgment about effectiveness. We really can't expect more precision and certainty than medicine can actually give us in these kinds of circumstances. And I think that people who have secondary scoring systems are just way beyond what's realistic. Anyone not needing a ventilator should be eligible for palliative care consult. They should be informed that they have been triaged out and provided the best alternative treatment. There is an ethical mandate to care for every single one of the patients, even if they are triaged away from ventilatory care. We ought to be treating the psychosocial and spiritual needs of our patients, making palliative care referrals, not only for people who've been triaged, but for patients who are having symptoms that are refractory to our standard treatment anyway. And pastoral care should be involved as best we can to address the spiritual needs of patients, even if they're not very physically symptomatic. But let's hope and pray that this doesn't come to rationing. And with that, I will open it up for questions from first from Nate and then from the rest of the audience.
All right, thank you so much, Dr. Solmesi, for summarizing some of the criteria that you think is most appropriate, as well as reminding us that in this time, it is the ethics that we have been always doing, slightly more important or maybe more enhanced or more critical, but we're still sticking to those same ethical principles that we were using prior to the pandemic. I think that's a very worthwhile lesson from all this. Moving away from the initial triaging, but let's first start with that. Let's start with the initial triaging. You recommend the Apache 2 over the SOFA, even though many policies out there now use SOFA. Why do you recommend the Apache protocol?
Well, it's a technical reason, and there are other intensive care doctors and other physicians who agree with me on this, that the SOFA score is better for predicting for people who are already on a ventilator and getting pressors, whether they're going to die or not in intensive care. It was not designed for initial triage of patients. And so unless you use a modification of it, for instance, among its criteria are whether the patient is on a ventilator or not, and whether the patient is getting pressors or not. Well, that begs the question. Those are the very questions we want to ask. So I think that probably the old Apache 2 would actually be a better predictor because it was designed for initial presentation rather than whether the person is going to make it out of intensive care alive.
So that seems to then raise a follow-up question of, if Apache is good for the initial triage, should we switch to SOFA as we begin maybe time trials, as some of these protocols recommend? So are time trials appropriate? Do we switch scoring systems? Is there a way that we do this once they're on a ventilator?
Yeah, again, none of these scoring systems have actually ever been proven better than a clinician's judgment. And my view is that time trials are reasonable in this situation in the same way they would be reasonable in other situations outside of COVID or outside of rationing. Just whether this is actually going to prove to be effective or not. If somebody wants to use a scoring system to help with that, that's fine. But I think if it gets to the point of what I would call physiologic futility, to a reasonable degree of medical certainty, the clinicians who are treating the patient can judge that the patient will not make it out of the hospital alive, even if you're giving maximal care, whether that's using a scoring system or not. That's a point at which I think ethics as usual could be invoked, that we should not be doing physiologically or biomedically futile care for patients, and that at that point, the treatment could be stopped, even, I would say, without the consent of the family member at the point of that physiologic futility. A trial of just 3 days, for instance, for COVID-19 is not going to work because people seem to need an awfully long time on the ventilator if they are actually going to make it. Many of the people who have survived have been on for 14 days or more. And I think you had a session last week, so I won't repeat it, on why it is that I don't think we should be taking people off ventilators after 3 days and giving them to somebody else we think has a better chance of effectiveness. Once they're in the system, we ought to be committed to trying our best to care for them to the best of our ability, unless they either say that they think it's become extraordinary for them or their family judges that, or it's become biomedically futile.
Thank you. So far we talked about rationing of ventilators, but what about, we're finding other scarcity around treatments, especially for dialysis, inpatient dialysis, other kind of intensive medical options that might be tried for somebody who's experiencing COVID-19. Are you recommending a similar type of principles, the similar type of diagnostics and prognostics as you would for other treatments as you are with ventilators, or is this completely different?
Well, the SOFA score itself really is probably reasonable in terms of, or Apache score, again, reasonable in terms of overall prognosis. And usually the way things work is the first decision is whether to get the person into the intensive care unit and onto a ventilator, and then later complications will fit in. I think the principles, though, apply equally. It's need, prognosis, and effectiveness, right? If the person is on 3 pressors and hypotensive, and their fever is up to 106, and they're on maximal ventilatory support, I think any reasonable clinician would be able to say that under those circumstances, dialysis is not going to help that person to get out of the hospital alive, and would not be something that should be offered. But there are other things that people have been doing, which I think are probably reasonable, which is trying to stretch the resources. And again, this is a way that I think we can invoke solidarity and the common good to give everybody some chance. For instance, without enough dialysis machines in New York, I know what they've been doing is a slightly shorter duration of dialysis so they can maximize it to give it to more people. So we can stretch things as long as we're trying to treat everybody equally and fairly as best we can, short of the point where we say this has become either biomedically futile or the person, as they often will in intensive care, will say, I've fought the good fight, I have run the race, I've kept the faith, this is as far as I need to go, and I will desist in further treatment at this point.
Let's get to a fairly contentious part of all these policies, and you've kind of raised it, and it's this use of age. Either as a elimination exclusion criteria for somebody over a certain age, whether it's a tiebreaker. Some say it's just their normal age, life stages, and in fact, the Apache score uses age as one of its criteria. Could you discuss a little bit more about why you're against the use of age and how the use of age in the Apache score is not as discriminatory, but rather is more for diagnostic decision making?
Yes, any of those scoring systems, even if they don't actually say age, in some ways build, bake age into the scoring system, because it's about the physiologic status of the person, which is a predictor of whether they're going to be able to benefit from the treatment in the first place. It probably stands as a proxy for things like the robustness of the immune system, the number of stem cells one has, the propensity to have pre-existing atherosclerotic disease, which has not even been detected, all those sorts of things, which I think it stands for. But again, when it's being used in a predictive model like that, it's being used to ask the question whether this treatment is effective or not. When we get outside of that and start saying, well, nobody over the age of 65, since they have a bad prognosis, is going to get a ventilator, then I think we're actually behaving in a discriminatory fashion, because it's the age itself becomes the criterion rather than the person's capacity to benefit from the ventilator. You could have a 33-year-old with advanced cystic fibrosis whose prognosis would be much poorer than a very fit 65-year-old, right? So we've got to, I think about whether the treatment is worth it for this patient, not whether the person is worth being treated. That's the principle. Now, the life years approach, I think, is a tricky way to think about that. I know people sort of suggest, oh, well, younger people ought to have a chance. And I think in charity, one could very well come to that suggestion, right? But I think that that's a personal suggestion that I am out as an act of charity saying, let the younger people have my shot at the ventilator. I've lived a good life. That's very different from having a rule that says you're not even going to have a chance to give it to somebody else because we have decided that you're too old to deserve one. I was thinking of this actually a few weeks ago during the readings of the Passion, right? Caiaphas says it's better for one man to die for the sake of the country, right? That's the utilitarian approach. The same thing happens, but Jesus's approach is, I am the good shepherd. I will lay down my life for the sake of the others, right? A world of difference between the same event, whether it's done freely by the individual as an act of charity, or whether it's imposed on somebody as a utilitarian scheme ahead of time.
We only have a couple more minutes, so I want to conclude with your thoughts and something that you kind of raised, I think that's underlining everything you just presented about, and it's personal clinical judgment. It seems as if these criteria are not there to replace the clinical judgment, but are rather there to provide some sort of boundaries or some sort of cohesiveness between all the different entities that are at play in this time of crisis. So how would you describe the role of clinical judgment? But also, it seems as if we need to ensure that our healthcare professionals have good ethical formation so that they're able to make the ethical judgment as well. How would you speak on that for just the last moments?
Sure. Well, I think it's a combination of both principles and virtues, as I began, right? The active virtue here for the clinician is practical wisdom, or as the Greeks called it, phronesis. That's the judgment, right? And again, to the best of my knowledge, none of these scoring systems have ever in the end proven better than the judgment of a clinician. So they're there to help take the burden off the people who are caring for the patient and to provide some uniformity. But once you're in the intensive care unit, my view is that the commitment to caring for that patient and the judgment of the clinicians who are caring for them, which is the normal course of good ethical medicine, should be what guides decision making. And we can never escape from the necessity of clinical judgment. Aristotle said it's like the rule of the Isle of Lesbos, that you can't give exact formulas for these things. You've got to be able to have the judgment to bend the ruler made out of lead around the situation and fit it to the situation. That's what clinicians are trained to do and best at. But as you suggested, if they are properly ethically formed, they'll be better able to do so.
Well, Dr. Solmesi, thank you so much for the half hour that you just provided for us, for going through some of the challenges of a rationing criteria and the triage protocol. And I thank you very much again for your time as we get into the second half of our hour.
My pleasure. Thanks for having us and for helping to sponsor this from the CHA's point of view. Thanks.
Thanks so much. For the second half, we're going to turn to two other presenters, David Miller and Claudia Sotomayor. And so we will have them come up on screen to present on the topic of whether healthcare personnel should receive preferential treatment during the COVID-19 pandemic. So I'll let the two of you begin our conversation together.
Thank you, Nate. First of all, thank you all for having us. We're thrilled to be here. And the way we thought about this presentation is more dynamic, where we're going to have a conversation, David, Nate, and I. We went through some literature out there and found different arguments, and so we're going to try to go through them through different lenses, particularly the Catholic perspective of these questions. Should healthcare personnel get preferential treatment during the COVID-19 pandemic?
Thanks, Claudia. And I will send to Nate the resources that we use so that people can look at our sources to see where we're coming from and see these arguments more in depth. But generally, we want to examine different arguments for and against the proposition that preferential treatment is appropriate, and we'll look both at secular and Catholic perspectives. I think that in the end, we may wind up problematizing the questions more than providing authoritative declarations, but Claudia may have come to an authoritative declaration, so she may be more authoritarian than I am. We'll see. But to start off, what we'd like to do is just get your juices flowing. We'd like to get a quick gut check poll. And we'll give you 45 seconds with a 10-second warning before the poll closes, just to answer this one question. So just to get a sense of where people are coming from, we'd like to see that. We're curious about that. So please just give it a quick thought. What do you think? Should medical personnel get preferential treatment during the COVID pandemic? You've got 45 seconds. Oh, maybe 30 seconds, because 45 seems like an awfully long time.
Yeah.
If you want a real gut check, you need to have it as short as possible.
All right, 10-second warning. All right, great, thank you.
Can we get the results? Okay. Oh, interesting. Okay, so 50% of you. Okay, it's kind of half and half. We'll see how if you change your mind or if it remains the same. This is very interesting.
Yeah, and maybe we can make some distinctions, and that will help you to see what it is that you really think about the topic. So let's look at the first question. I don't know, basically one of the questions is, if we already have a SOFA or Apache system that Dr. Solmesi just talked about in the last session, it might not seem reasonable to distinguish between medical personnel and other patients. And I would say that ordinarily our healthcare system does focus on providing healthcare to people based on need. There are background disputes about access, cost, and quality, and insurance, et cetera, that are constantly going on in the background. Individual need is the primary focus of the medical system. the stewardship of resources is a concern, but we sort of leave it to the administrators, and in the back of people's minds that the system will take care of it, and really what the healthcare practitioner should focus on the patient in front of him or her. But during an infectious disease pandemic, the scarcity of resources may force two considerations to the fore that are normally not considered. One is the absolute scarcity of resource, and the other is that the private healthcare system in which we're embedded is also a public healthcare system. It may be that the volume of patients, particularly the seriously ill, threatens to overwhelm the system as a whole, and the direness of the situation can be exacerbated by the need for extra precautions. So there's a need to focus on the individual, but there's also a need to focus on how the system as a whole is functioning. The healthcare system, the infrastructure, which is already always strained by the uninsured, the underinsured, by governmental programs and entire hospital systems that operate within very narrow margins, the focus on just-in-time planning, insurance churning, inefficiencies, fragmentations, market forces, all of these things threaten to overwhelm the system as it is, but now it's threatened even more by the number of people needing care and the number of healthcare professionals themselves who may become infected and need care as well. And so that's, I'm not saying that we ought to change our focus, but we're saying that these issues come to the fore in a way that they ordinarily are in the background and are not really attended to. Claudia, what do you see?
Well, I think I will step back a little bit and say, well, yes, we have a scoring system, but I want to remind you that these scoring systems are used in triage situations, the extreme of the extreme. And I want to focus more, this presentation will focus more on other type of treatments and maybe prevention at a preventive stage, where the SOFA score, the Apache score is not going to be applied. So in those situations, we have to think about, are we going to provide or distinguish this preferential treatment for our healthcare personnel? From a sort of Catholic, well, I say sort of Catholic because I am not a theologian, but if we think about the common good from a Catholic perspective, not, and I want to underscore these, when we talk about the common good from a Catholic perspective, we are not doing a, I don't know how to say it in English, correct me if I say it wrong, arithmetic, is that how you pronounce it? Yeah.
Arithmetic.
Where the person plus the other person plus the other person then becomes the whole, and then each person is less worthy than the whole. From a Catholic perspective, that's not what it is. The person, like each life, is part of the whole and vice versa. And we would see it as, we might even see it as the mystical body of Christ, which each individual is part of that mystical body of Christ, and therefore has this special worth. And with that in mind, I want to, whenever you hear me saying the common good, I'm referring to that common good, like a holistic approach to the common good. So I think we can focus a little bit on the common good from a Catholic perspective to solve some of these questions.
Great. I think I may have a slightly different conception of what the common good is, but I'm sure we'll come to that later in this discussion. So one of the things that we thought was important to discuss right at the outset is, what do we mean by medical personnel? Who are medical personnel? And, you know, as we consider the need to sustain, I'm really thinking of this in terms of a healthcare infrastructure and medical personnel. It's useful to consider medical personnel as sort of radiating in concentric circles from the patient's bedside. So we have emergency and critical care providers, respiratory therapists, ancillary healthcare workers, such as phlebotomists and pharmacists, nurse aides. But then in hospitals, we have the food service providers and maintenance and custodial workers. So there are so many people involved in this, and it is, I will argue, it is difficult to determine which medical personnel we might be thinking of and which are essential and which might need or deserve or merit preferential treatment. But I think it's worth considering that. We also need to consider the personnel at retirement, assisted living, and nursing facilities, which rely on physicians and nurses, but also nurse aides and other caregivers who are not necessarily as highly educated and specialized in their training, but who are essential to taking care of all of these people and who play a role in maintaining the whole healthcare infrastructure. They're essential workers as well. And so we'll have to think about that in more depth later on. Claudia, what are the statistics on infection rates?
Well, but before we go, yeah, I agree with you completely. The definition of healthcare personnel is tricky, as you mentioned. Who are we going to consider a healthcare personnel, and therefore who are we going to potentially give preferential treatment? And the Morbidity and Mortality Weekly Report of the CDC Task Force defined it very interesting, and I'm just going to read it to you. They defined it as the paid or unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. So as you can see, it's very broad. Basically, all the people that you were mentioning, David, would be considered healthcare personnel if we go with this definition. Now, I think this is relevant because our initial question is relevant because this is a very simple graph. But it's basically a representation of what this Morbidity and Mortality Weekly Report is telling us. In this report, even though they are coming up front and saying this is obviously an underrepresentation of what might actually be happening, they're saying out of 300,000 patients reported up to April 4th, I think, only 50,000 of these reported the profession of these people who were infected, and of these 50,000, about 9,000 were medical personnel. So there is, which would be the 20% of this population. So if we think about it, it's a lot. Our healthcare personnel, given the fact that they are being exposed to the virus, obviously they're getting infected. So that's a thing to consider.
Right.
Thanks for starting with some of the ground kind of definitions and where we're going with this. So let's start into some of the arguments that I think a lot of people are putting out there, either in the media or in actual academic journals, in medical journals, for example. And here's one that is actually in favor. After all, they justifiably receive priority for other things like vaccines based on their increased risks due to clinical exposure, as well as their potential role as vectors of disease. Let's look, for example, David, you mentioned nursing home and retirement home workers who, for many of them, work 2 or 3 different jobs. So they could become a potential vector between the homes or the different workplaces. So in this argument, people seem to be in favor. How would you respond to this, or how would you defend it if you are?
I would say that I would pull out 3 different types of treatment that we could foresee. I would say one would be prophylactic treatment, such as vaccines. Another might be antiviral drugs, such as the one that's being developed, remdesivir, that shows some promise, and other life-sustaining measures, so ventilators. And I think that there are 3 separate categories. They may overlap. Antiviral and life-sustaining measures may be similar, but I would want to make a distinction there. Claudia, did you?
Yeah, I agree. I think we have to, when we talk about treatment, we have to think about different levels of treatment. When we have a vaccine, we are providing a preventive measure to the healthcare personnel. And I would even dare to say that the vaccine and the PPE are equally worth in the sense that they're both protecting not only the healthcare provider, but the person they're treating, right? we all know that if we give vaccine to someone, let's say in school, they ask you to be vaccinated because that way you're protecting those who cannot get vaccinated for whatever reason. So in this case, I think healthcare providers should get preferential treatment in the sense that they need, if we give them vaccines, potentially we will be protecting themselves and others, the other patient, their family members, et cetera, et cetera. Yep.
I was going to say that when I thought about this, I immediately thought of the airlines when you get on the plane and they tell you in case the masks fall down, ensure that your own mask is secured and functioning properly before assisting someone who needs assistance, children and others who need assistance. And I thought that's really doubly meaningful in the context of medical personnel's work in providing care during a pandemic.
So this seems to raise to both of your points about the different levels of treatments, different levels of what's actually being preferenced for a healthcare worker. And in this case, a vaccine might be something reasonably given to healthcare workers before others, or at least earlier on in its administration.
Correct.
Now, it could be argued that we give priority to treating physicians and others because they can then treat others during the pandemic. So that, like the frontline soldier who gets injured, we want to treat them to get them back on the front lines. I don't always like using the battlefield metaphor for these kind of things because it seems to lack a sense of compassion, but this is what this argument is trying to state, how we want to treat a physician so that they can get back into the working of treating others. How would you all respond to this argument?
Yeah, I would say that if an effective treatment were developed that could shorten the duration and severity and intensity of the illness and allow a quick return to work, I would argue that in general, medical personnel should be given priority in receiving that treatment, if doing so would allow them to return to their posts to provide care to others who need it. This is not, I don't think that this is an appeal to their social status. I don't think it has nothing to do with their rank in the social hierarchy based on honor, wealth, fame, prestige. It may have something to do with education. It's a recognition of the fact that their specialized training makes them difficult to replace and an essential support for the system. In some ways, so Claudia mentioned earlier the common good. I tend to think that I have a more, I guess, theoretical conception of the common good as that, and it's recognized in political theory as sort of the centrality of public or social goods and services that are needed as a foundation to sustain society. So from public lands to public education to public sanitation, policing, emergency services, et cetera. And I think that, during a pandemic, the network of private healthcare institutions have a role as public healthcare institutions, and they're foundational to allow all of those other functions to go on. And so, sometimes I would say when the healthcare infrastructure itself is threatened, despite it's not being clinically relevant that someone is part of that infrastructure, it is still morally relevant when that infrastructure is threatened. And now the whole structure isn't threatened now, but we can talk a little bit as we go a little bit further about what would happen in that case. But in this case, I would say that there is some reason to give preferential treatment for treatment.
And with this argument, I have a little bit of maybe hesitation. And the reason is because when we use the social utility argument, or we put social utility as the reason why we are providing preferential treatment, I think is dangerous. I think we're in danger in danger of falling into a very reductionist approach to what the human being is. We're reducing that physician, that nurse, that healthcare provider to whatever they know to do, right? Like, you're useful to me, so I'm kind of using you. And I think it is important for the healthcare system, especially a Catholic healthcare institution to be very aware that we need to protect that dignity. However, if we focus that approach not in the I'm going to give it to you because you're useful to me, but I'm going to give preferential treatment because we are all part of this mystical body of Christ, and this body of Christ right now is hurting. And somehow we need to everybody needs to use our gifts to help this body of Christ heal. Under that lens, I maybe give some priority to have access to certain medications that can potentially restore their health in a quicker manner, so they can go back and give these talents to others, so we can relieve the pain of this aching body of Christ. But again, we need to be very careful how we're framing this question, and always making sure that we're protecting the dignity of the human person.
So it sounds as if that there are some very good reasons why we may want to prefer treatment for healthcare workers. Some include, as they say, that they can treat others, that it will continue to maintain our healthcare system. We have to think beyond the pandemic. If we lose a lot of healthcare workers to this disease, what will our healthcare system look like even when we get past this crisis? And we already have a shortage of people. But Claudia, you're pointing out a very real problem in just its applicability and how we actually use it and how we actually say it. We don't want to treat people as if they're tools, as if they're useful. And so we need to steward them like resources that we would any other resource that we have. But instead, how do we uphold their human dignity so that they are able to give of themselves, give their talents for the greater and common good of others? So it seems like, again, we're back at a kind of a tension here. Next we have, sorry, Dave.
I guess I want to resist saying that we're using these people in a certain way, and that we're either privileging them and then having some sort of utilitarian advancement of their social work, or that we are reducing them to tools to be used by the system. I think that, you know, each of them does have dignity. Every person does, and each person plays a role, and we're recognizing that role, that the structure of society really has a foundation, and if they play foundational roles, that we have to protect them for those reasons, and that they will go out and shepherd and enhance the human dignity of all the people that they treat. And if they're unable to do that, if they're taken out of circulation, there's a loss to everyone. And so it's not that they're more valuable than others in a sort of metaphysical or spiritual sense, but they are, they have a particular role that we need to recognize and in extreme situations, value in a particular way. I'm not saying this should be always the case, but in some cases.
Yeah, I agree with you, but this is a point counterpoint type of situation. If we go through what you're saying, then the infrastructure and the value that they're providing to the society, how would you distinguish between the healthcare provider and the farmer, for example, who is also providing important things to us, right? We all have to eat. We all need milk or food or products, and there's so many people out there that are exposing themselves and doing whatever they can to sustain society at this point. So how would you distinguish between the healthcare provider and the farmer and the police officer and other members of society that are working right now, and they're not privileged as we are? We're at home. So I think that is the problem with that argument.
I could see that. All of those people are central to the infrastructure as well, right? And I think that this is something that what I do want to do, what I would argue for, is that we need to make space for these considerations so that we don't go, we don't say all of these things are something that they're either too difficult or they bring in social worth in a way that we can't look at them, and so we have to be blind to these things and therefore look only at SOFA scores and Apache scores. When we look at the system overall, we need to attend to the system as well as to like individual patients and at the bedside or when rationing decisions are being made. And I think it's something that a community needs to determine. How do we support the system? If the system collapses, then it's not doing anyone any good. And so we do have to protect all of these people, and no matter that it's something that needs to be discussed and deliberated over on in a democratic way within a community, and the community needs to determine how it wants to support the common good and how that support and what the need is, how that will affect the way that the treatment is distributed to some extent. I mean, there's still going to be, it can give an outline of it, but it is something that needs to be discussed and determined within the community. It is a common good, and it is something that community needs to determine, I would argue.
So to make sure we have enough time for the second round of polling, not problem. It is a good conversation. We're getting into a lot of the nitty gritty about all these different arguments. So here's an argument that, correct me if I'm wrong, is saying that they shouldn't be given preferential option because there's an ethics component. They're bound to treat others. There's some sort of social contract. How does this argument get played out in policymaking around preferential treatment?
I'll start if that's okay. I would say that this issue really, in my mind, comes to the fore when we think about the situation with PPE, with personal protective equipment now. I think there is a social contract. I think that healthcare personnel go into their professions knowing that they will face greater risks, knowing that they're doing something for society and that they run a risk. And they're willing to do that. And if there is a social contract, I think that the other side of that contract is that they will go in doing that, but they will do so with proper protection and proper support from society. And I think that so it depends. Some healthcare institutions have done better than others in terms of making up for the lack of PPE, but I think they have a reasonable expectation that they would be provided with personal protective equipment, and that when that equipment is not provided, that society has failed on its portion of the contract. And although I would not say that it would be a compensation to give them some sort of prioritization in treatment, I would say that it would be a way that society or the community acknowledges that there has been a failure of the government and of institutions to uphold their end of the contract by doing this. Now, whether they could have foreseen it and whether they could have foreseen what was needed, et cetera, is open for debate. But I do think that there is that the contract there are at least two sides to that contract.
Great, thank you, David. Claudia, do you have any thoughts on this?
Well, I think it is true that they have some duty to a professional obligation, an ethical professional obligation when they profess an oath, as Dr. Denzel Macy was telling us about, right? And actually you can go and see the code of ethics of several different organizations, and they will explain. And for example, the American Medical Association has a statement, very clear, opinion 8.3, I think it is, where they say, well, in an epidemic, or in a natural disaster, we have to do our job, basically. So yeah, I would agree with David in the sense that, yes, they have a professional responsibility, but every responsibility comes with a counterpart, right? I have this responsibility, therefore I need some protection, or I need some quote unquote rights. What are my rights? At this point, you can say, well, if this person comes to work and is professing this social responsibility, the rights is at least to have the minimum tools to be able to profess that profession correctly. And so those tools are proper PPE, vaccines if we have them available, or everything that is needed for them to do their job. When that for some reason is not provided, either because we don't have enough, either because there's some failure in the system or whatever, you name it, then we need to think as an institution, how are we going to protect or to provide that safe working environment? Ethical Religious Directive number 7 states that, or talks about the responsibilities of the institutions towards the employees. And it says that every institution should provide a safe work environment that ensures the protection of the well-being of the person. In a pandemic, how are we going to make sure that we're protecting the well-being of our employees? That's the question that I want to leave to the institution, right? How are we going to protect them? David was talking about compensation, and compensation can mean anything. I mean, how are you going to compensate? Are you going to compensate by giving them some hazard pay, or are you going to use preferential treatment as a way of compensation? I think that is a conversation that needs to be held, maybe. And maybe I don't have an answer for right now. But it is something to consider, right? Are we going to give them preferential treatment as a compensation, or are we going to give them hazard pay, or are we going to give both? What do you think?
That's a whole nother topic we have to get at, right?
Yeah, I'm looking at the clock. I know that we've already run over our time by a couple of minutes, and so I feel bad about that because we didn't leave much time for discussion or even the closing poll. We could put the closing poll up there and have people take it, so because I would love to see the response to post that later.
Yeah.
I'll leave it up, and I'd like to sort of, if you don't mind, I'd actually like to sort of give my sort of summary statement, just because sort of bring together what I think is my sort of overall train of thought. So I'll do that quickly. And I would say that a combination of a pandemic, infectious disease, a failure to prepare for that event, an already overburdened and fragmented healthcare and healthcare financing system, and a series of imprudent decisions at the highest levels of leadership has led to our current situation. If it worsens, and if the nation's infrastructure, particularly its healthcare infrastructure, is seriously threatened by the disease, at some point we may have to make some very difficult allocation decisions. Prudence dictates that we protect our healthcare system. Depending on how the current situation develops, privileging healthcare workers for vaccination and possibly for treatments when illness incapacitates them may be necessary to advance the common good. The catastrophe doesn't and should not cause us to abandon our principles or values, but it does force us to recognize the social foundations and infrastructure that we ordinarily take for granted and fail to properly maintain.
And I would just add quickly that I would echo what Dr. Solmesi said at the beginning. Don't change our ethics. And we're seeing this in the lens of justice, right? How are we going to be just? But I want to invite you all not to just consider justice when you're thinking about this, but also think about the other virtues. How are you going to apply temperance, avoiding aggressive treatments, for example? How are you going to be prudent and be a good steward with what we have right now? And last, how are we going to be strong? Our fortitude, right? Not succumb to fear, trust in God, do our best, and always have that eagerness to do our best and the best thing we can do for the common good and for humanity.
Well, thank you both. Let's see what the poll results
Yes.
have told us about the conversation so far.
Okay. This is very interesting. So yes and no. I think I would agree with that answer. Yes and no. Vaccines, yes. Effective treatment available, yes. ICU in critical situations, the vents, for example, I would say no. Yeah.
Yeah, I mean, I would personally fall somewhere between number 2 and number 3. But I do think that in particular situations, you know, that we do have to take these concerns into account, even with treatments, not just prophylaxis. But thank you.
Yeah, so I think this, no, you're quite all right. I think once again, it highlights what Claudia just said and what Dan said before about the need for just good prudential wisdom, good ethical decision-making. You know, these things aren't going to just reveal themselves as right or wrong, that we're going to have robust debate and discussion. And I think we just saw that today, and we see that right now in the actual polling question. So I wish to thank both Dr. Miller and Dr. Sotomayor for their wonderful presentation. And thank you, Dr. Solmesi, for your first half of our time here together. And I wish to thank everyone who has participated with us today. And we hope to see you next week for our next and third session of the CHA and Georgetown University presentation. So thank you all so very much. Presenters, you may now close your videos, and I'll return it back to Ronnie at Blue Sky to finish up for everyone. Thank you.
Thank you.
All right, thank you, Nate. And on behalf of the Catholic Health Association and Georgetown University, I'd like to thank you for your participation in today's event. A recording of this event will be sent in an email and will also be posted on CHA's website at www.chausa.org/coronavirus. This concludes today's program. Thank you for joining us and have a wonderful day.